Dr. Pellegrini is the professor and chair of surgery at University of Washington in Seattle. He's chair of the Board of Regents and has really been the driving force between the development of the accredited educational institutes of the college, and has been a big advocate for structured training in surgery. I'm delighted that he's here to speak to us this afternoon.
Thank you, Jerry. It's a pleasure to be here. I know that as you look at me, it's a pleasure for you to find me here as well, because you know that I'm the last speaker. The good news is that I am the last speaker. The bad news is that my 20 minutes, I think, have been used pretty much. So I will try to give you a sense of what the role of the chair is. Here are my disclosures. My spouse works for Covidian. I am a consultant for some of these companies listed here, and I will be showing you a couple of pictures that include products from these companies, so you may want to put that in the whole context of my talk. There's another disclosure. I'm a friend of Jerry Fried. That's why I'm standing here. And I just found out today, like you did probably, that he was the recipient of the Distinguished Service Award, and I want to congratulate him publicly with that. So I was asked to speak specifically about the support of the chair and what role does it play in the incorporation of a successful simulation program in a residency training. And I will therefore talk to you about the topics that are listed here, which I think are central to the job of the chair and things that the chair can significantly influence to yield that successful integration into the residency program. And I will go one by one, and when I get to the end, you will know that I'm at the end. In doing so, I will give you personal experiences in most of them with a little example of how we have managed that situation in Seattle. It's not supposed to be necessarily the only way, but I think it's one way of doing things, and is the only one that I know. So let me start by developing a simulation center. And we could look at the rationale, but the preceding speakers have spoken abundantly about the rationale for having a simulation center. There would be a long list here if I really wanted to have them all. I think the role of the chair, which is my task here, is that the chair must work with the institution, and I'll show you some ways in which one can do that, to obtain either an initial capital resources to develop a simulation center or to craft agreement with existing centers in geographic proximity. And I think that this is a very important distinction and a very important first step to take, to make the decision, as you have seen before, as this becomes more and more expensive, what is it that we have in mind? Do we want to have our own, or do we want to develop another one? As Karen told you, I have the privilege of working with Karen and the same institution. We chose to develop our own center, and this is the entrance of the center. We decided to make it very public in the institution for reasons that you will see in a few minutes as well. We decided that it was important that the center be accredited by the American College of Surgeons. I suppose that's another conflict of interest, since I was chairing the accreditation process at the time, and I was very interested in having as many centers as possible accredited. And this is also accredited by the American Society of Anesthesiologists. Now, why is this important? I think as you are thinking about having a center, I believe that the program of accreditation that the college has is important in at least one major area, and that is that all centers that are accredited become part of a consortium, and the consortium can certainly help create many of these programs that we were talking about before, bring new ideas and serve as a platform for either validation studies or launching other programs. It is important, once you decided that you're going to create your own center, to develop a vision for that center, and if you decided to go the other way and have agreements with others, see the vision that they have for it. I'll describe 4 or 5 aspects of our vision when we created the center. We decided from the beginning that this was going to be interprofessional, so we were going to have nurses, pharmacists, public school, School of Public Health individuals that will contribute in different areas. To that end, we got 20 departments on the school to sign into a single center and decided that there will be economies of scale associated with this. There are also problems associated with that, so you have to make up your mind. This is a way to show that, in fact, it is multidisciplinary and it is interprofessional when nurses and, in this case, an OBGYN person is trying to deliver a baby on a simulator. We decided, furthermore, that the center was going to be, in our vision, a curriculum-driven center. So note that we put the simulators, low and high fidelity, down here. They are preceded by the development of a skill that it defines the needs that we have, develops didactics, evaluations, etc., and chooses the appropriate simulators based on the needs that we have identified. For example, Karen talked about the FES, and when we decided to do that, then we have a curriculum that we're going to apply, and then we buy the simulator appropriate for it. And as Karen also told you, we decided strategically that our deadlines would be to train the residents as they move through just-in-time education, that is, do pre-training before they go into the area of clinical experiences. Further, our vision included training to competency rather than training to time, and we have discussed that before. Going beyond psychomotor skills, so we wanted to bring in team training concepts. We wanted to bring in error disclosure training. We wanted to bring in the interprofessional stuff that I discussed before. We decided that it would be a research focused both in education and also in engineering tools. We decided that it would be centered on residents, and this is different than other centers in the sense that, and it's a decision that you have to make, whether you are going to concentrate in giving courses for physicians, or you're going to dedicate the resources of the center, limited as they are, to the residents. And we decided that we were going to be active on the area of patient safety, and made a special memorandum of agreement with the hospitals that they would pay us a certain amount of money for us to deliver on safety. And this is a concept that I would like to expand a little bit more, because it addresses one of the questions that Melina just posed to you. She said that you could show training in simulation made you better in simulation. You could show sometimes that made you better clinically, but she said there are areas of safety that have not been yet recognized. We took a project, we found a need in the hospital where we had variations in technique, not routine use of ultrasound, lots of complications with central venous catheterization, and decided that this project would involve all attendings, all departments, because we are a multi-dimensional center, and it would apply to any individual that would place a central venous line. All those individuals would have to train in simulation and be certified after demonstrating a certain level of competency with this type of summarized training before they were allowed to put central lines. So they all went through a cognitive simulator, technical skill simulation, and then we had a system-wide QI process where the hospital became a network in there by having uniformity of equipment. This saved the hospital a tremendous amount of money because the curriculum established how we did it, what instruments we used, what type of draping we used, what type of catheters we used, and so the hospital could streamline its inventory significantly. And then we decided that we would track all lines placed so that we could see infection a year before and a year after starting the training. And you can see here that this was the infection the year before, and this is the infection. This was the projected one, the goal that we had established to call it success, and this is where we ended up last year with infections in central venous lines. So there is a potential for having a significant impact in safety, and we have now quantified this in dollars. And those dollars are the dollars that now the hospital is quite willing to put in subsequent projects to help finance the center itself. One of the roles of the chair, where the chair can be most effective, is in the recruitment and the support of the faculty. And those are two different facets. Recruitment of the faculty you're going to find, if you're a chair, that just about any very young person would be interested in teaching and would be interested in participating. Retention of the faculty and avoiding the revolving door. As faculty spend some time and grow older and realize that this is a difficult source of funding and so forth, becomes a little bit more difficult. So focus in research while trying to retain a person, opening large grants and program support for education and so forth, as well as providing documentation towards promotion, something that Karen said is viewed with lukewarm in the faculty of the Department of Surgery. It has been important in other departments in keeping faculty in our center. Also, in terms of faculty, use of non-physician trainers, something that we have not yet emphasized in our center, but as it becomes more and more expensive to have individuals who could be doing procedures do training, we believe that these individuals may play a great future, a very important part in our future. And self-training, as was shown by previous speakers, are all strategies that we can take for the faculty. It is important for the chair to set expectations for the residents and the faculty for participation. And I can't emphasize that enough, because if we chairs were to leave this just to the program directors and put it in the lap of the program directors and expect that that will carry the weight in this very difficult environment where we are balancing the work hours with a number of other clinical needs and the numbers for cognitive learning, et cetera, this can be very difficult to do. All the chair has to do is to simply not only direct a few resources in the direction of those who are working on the center, but also really emphasizing at every time that they have as an opportunity to the residents and to the faculty, this is important. I don't think that anything could be worse than a chair simply chastising a resident that is late because the resident was in the simulation center when the resident was attending a predefined part of the training curriculum. So we have a defined training curriculum. I think Karen told you a little bit about a technical skills rotation. This is a rotation that has a few other things included, but it's a non-clinical rotation that is given 2 months to every resident every year of the program. And we have a protection of time on Wednesdays where the residents have mandated time out of clinical services and are devoting their time to activities that have to do with technical and other forms of training as well. And then having an annual technical skill portfolio available too. The intern curriculum, as you can see here, contains a number of things, and these are not to go through in detail, but there are things with schedules, with direction specifically as to where the materials are found for these individuals to be able to do that. Funding this initiative is certainly one of the most important things for the chair to do. There is probably, between the creation of the vision and the recruitment of the faculty, I would say the second or third most important thing that a chair can do. So that means who should pay for simulation? Because all the good things about simulation are true, but that is part of education and training, and education and training is something that most places are trying to shuffle it to others to pay for. So one of the strategies that I have followed, and I would recommend that you think about it, is who benefits from having a simulation center. The school benefits, because now we have incorporated third and fourth year medical student courses into the simulation center and specific programs that the school is interested in advancing, placing them there, okay? So they should have a partnership into it. And we have the school currently paying for 1/3 of the costs of having the simulation center, those costs that we cannot defray with grants or any other activities. The department, the different departments that are participating, because they have specific needs, whether it would be the needs of anesthesia to intubate patients, the needs for neurology to have lumbar punctures done appropriately, or the needs from gynecology to deliver babies without having brachial plexus injuries. Every department can bring a small amount to the center. Most of the capital resides in the hospital in the United States, and probably in Canada is the same thing. And so the hospital is a very important partner in the funding. I think something that is a win-win situation that I have exploited with great satisfaction in the hospital is to say, what is it that you need? And the hospital invariably tells me, we need to save costs and we need to improve quality. And so for those things, we know how to do it. If we create curricula that decrease the number of variations in any procedure, decrease the number of instruments used, decrease the number of devices, it makes a uniform kind of device. And that's away with a lot of cost up front. And then provides adequate training and tracking of results so that we can have an effective use of complications. We can do both. We can improve the quality and decrease the costs. And they have, for the most part, bottomed that argument. The insurance industry is another one that is helping us in different ways. Both the healthcare providers, third-party payers here in the U.S., and the malpractice side, both benefit from having better training, less kind of complications. And finally, the other side is to look for, in the public arena, where the public benefits from our activities, and grants and research are available, and I cited the Department of Defense, the Agency for Healthcare Research and Quality. We have funding, significant funding, from foundations. Unfortunately, all those fundings that we receive, substantial as they are for projects, and projects consume time and people and resources, so they sort of chase each other, and they don't help sustain the platform itself that we need. And so that is another bit of a situation that you have to be careful with what you're asking for. But there are now specific areas in foundations, and probably soon in the federal government, destined to sustain the platform that simulation entails, and that may be a good thing. So how do you sell this to stakeholders? This is just a graph, the major graph of the UW Medicine strategic plan. And we look at the strategic plan of the entire university and put the three areas that we insert in. And we say, this is what we fit in the entire strategic plan of the school. And we talk about that, and we show pictures about that, and we try to do advertising within the organization about the value of the center, whether it's in quality, cost, safety, et cetera, et cetera. Compliance is a very important aspect, and unfortunately a very big deal nowadays with us in the Department of Surgery, and chairs have to look into this. How many hours are the residents working? Is this part of the program? Is this exceeding the requirements, et cetera, et cetera? Are the residents going? And if they are not going, are they appropriately managed in terms of advising them and using the stick? And lastly, the oversight of the center. We have a board of directors. There are other groups around us, patient groups, potential donor groups, corporate relationships, and each one of those has a place on our very complex organogram. But I think that as the center grows and becomes a significant player within the organization, you have to be sure that you're sticking in some portion of the strategic direction of the university, and you have to be sure that you have an organization that leads to that concept of organizational excellence, an organization that allows you to carry on the mission. And this is just to show you some of the complex relationships between the different groups. So to summarize, what is the role of the chair in the successful establishment of a simulation program in residency training? I think it's central to the success of the clinical enterprise. I think it's a great opportunity for chairs to show leadership. And with that, I will close, and thank you very much for your attention.